4 to 6 hours. And 3, begin phototherapy and proceed for exchange transfusion. So we have 1 minute to answer. Correct. Most of you have answered correctly. So this baby has not been managed correctly from the outset. A baby with a blood group, having mother with a blood group O, may be at risk for hyperbilirubinemia if the infant is A or B. Another risk factor was the presence of jaundice shortly after birth and the 12-hour bilirubin, which was significantly above the 95th percentile. Answers 1 and 3 are incorrect because there is no need at this point to proceed for exchange transfusion, as many of these babies can be managed with intensive phototherapy and IVIG. Right. So question 2, 1.1 kg is born at 28 weeks of gestation and is on full total parenteral nutrition with minimal enteral nutrition. How many calories are needed to achieve a growth rate of 15 to 20 gram per kg per day? Option 1 is 90 to 100 kilocalories per kg per day. 2, 60 to 80. 3, 110 to 130. And 4, 140 to 160 kilocalories per kg per day. Right. Most of you have answered 3 as an option. So let us discuss. So the energy provided should meet the basic metabolic rate plus the energy cost of growth and losses, that is GI, urinary, skin, and others. Estimated energy needs of a premature infant to achieve growth rate of 15 to 20 gram per kg per day is about 110 to 130 kilocalorie per kg per day. That is for enteral. But when all or major nutrition is parenteral, the target is 90 to 100 kilocalories per kg per day, which is sufficient for the growth needs because there is no energy spent for digestion and absorption and fecal losses are minimal. So when significantly baby is on parenteral nutrition, the target is 90 to 100, not 110 to 130. That is the target when baby is on full enteral feeds. Right. So those who have answered 1 is correct. Now coming to question 3. A 27-week gestation baby was delivered vaginally. After 60 seconds of delayed cord clamping, baby was received in a warm blanket and immediately placed under radiant warmer and inside a plastic bag without drying. A quick assessment revealed poor respiratory effort and heart rate of less than 100 breaths per minute. Positive pressure ventilation was initiated using bag and mask and a pulse ox probe attached to the right hand to allow targeted administration of oxygen. At 3 minutes, baby had spontaneous breathing with a heart rate of more than 100 per minute. Which of the following is the most appropriate next step in the management of this infant? Continue positive pressure ventilation with bag and mask. Number 2, intubate and administer surfactant. Number 3, provide CPAP. You got 1 minute to answer. So moving on to the answer. The answer is 3, that is provide CPAP. Intubation and surfactant results in unnecessary ventilator-induced lung injury. Recent trials have shown that strategy of delivery room CPAP with later rescue surfactant to babies below 30-week gestation reduces the intubation in delivery room and overall duration of mechanical ventilation. And it also, meta-analysis have also showed that a slight reduction in BPD at 36 weeks with CPAP. And the recent European Consensus Guideline 2022 also recommends delivery rooms CPAP to a spontaneously breathing preterm with RDS in the delivery room and rescue surfactant when FiO2 is more than 30% on CPAP of 6 centimeter. Right. So moving to question number 4. As part of screening of critical congenital heart disease in neonates, we use pulse oximetry. When should we screen newborn with pulse oximetry to rule out CCHD? Where should we apply the pulse ox probe? When should we call it as a pass screen? What is a failed screen? And what should be the next step after a failed screen? So let us know the answer. So all neonates must be screened after 24 hours of age, preferably, or as late as possible if we discharge them before 24 hours. The pulse oximetry probe should be applied to the right hand, preductal, and a foot, that is postductal, simultaneously or in sequence. Okay, and this is the algorithm. So if the saturations are more 95% or more in the right upper hand and foot with a difference of less than 3 or less than 3% between the two, it is called as pass test. If it is less than 90, that is 89% or less in either right hand or foot, it is a failed test. Okay. And if it is in between 90 to 94, or a difference is more than 4 between the right hand and the foot, we repeat it after 1 hour. And then if it still continues to be 94% or less, or a difference of more, it is considered as fail. And it is 95% or more with a difference of less than or equal to 3%, it is considered as pass. So the next step in case of failed test is you rule out non-cardiac causes, because at times many non-cardiac causes like TT and RDS have been sepsis diagnosed with this pulse oximetry screening. So clinically you rule out them first and then refer it to echo for diagnosis of critical congenital heart disease. Right. So coming to the next question, name this clinical finding and associated genetic disorder. Nobody is attempting. You have to name this finding and the genetic disorder associated with both. Very varied responses are there. So let us find out what it is. So this is called miliaria rubra, characterized by salt deposition in skin and eyelids, deposition of eyelids, sebum in eyelids due to accumulation of salt in sweat glands and sebum in eyes. And this is classically seen in pseudo-hypoaldosteronism. Somebody has rightly pointed it out. So next question. A 30-week infant developed CLAPSI with blood culture growing staph aureus. And this is the fourth CLAPSI in your 20-bed NICU in last 2 months. What would be your best approach? And enlist 5 components of CLAPSI prevention bundle. So the 3 approaches listed here are: one is convene a committee of neonatologists to develop criteria to remove the central line sooner. Approach 2 would be meet with NICU in charge nursing staff to review daily central line care, because nurses perform all the daily central line care. Option 3 is use quality improvement methodology and track data to find baseline CLAPSI rate, review literature on prevention of CLAPSI, form a team and do root cause analysis, test change ideas, and then implement changes and sustain them to reduce CLAPSI. So what is the best approach? 1, 2, or 3, and then list 5 components of CLAPSI prevention bundle. You have to write the components of CLAPSI bundle. 5 components. Okay, let's find out the answer. So the answer is 3. So in quality improvement, it is a simplified WHO 4-step approach. That is, step 1 is identify the problem, form a team, and make an aim statement. The next step would be to do root cause analysis and develop indicators for the measurement. Third step is test your change idea based on your root cause analysis, modify them, and then implement them and sustain the changes. And the components of CLAPSI bundle care approach are hand hygiene, maximum barrier precautions, that is cap, mask, gowning, gloves. Then chlorhexidine skin antisepsis, optimal catheter site selection, that is avoiding femorals, and daily review of line necessity. Okay, these are the 5 components of CLAPSI bundle care approach. Coming to the next question, identify this equipment and write recommendations in NICU based on its use. So what is this instrument? And what are the recommendations in NICU based on its use? There's a clue in this photograph. Which will tell you what is this instrument. The unit which is written on the display is the clue. Right, some of you have answered after the clue. So it is a decibel meter or a sound meter, you can say. And the recommendations are that in the infant areas, combination of continuous background sound and operational sound should not exceed 45 decibel to 50 decibel. And transient sound has an upper limit of 65 decibel. And in the staff work or family area, it should not exceed 50 to 55 decibel and a transient sound of upper limit of 70 decibels. This is in short. Again, identify this instrument and write recommendations in NICU based on its use. Again, the clue is there. That also write the recommendations in short. Most of you have identified it correctly. It is a lux meter or a light meter. And the recommendations for light, less than 28 weeks, continuous dim light below 20 lux. After that, dim light at night and daytime, it should be increased to 250 to 500 lux. And in the infant care areas, it's no more than 10 to 600 lux as measured at bedside. And procedural lighting separately for each baby up to maximum of 2000 lux. Okay, so these are the recommendations. Coming to next question. Enumerate the 5 different approaches to reduce incidence of NEC, necrotizing enterocolitis. So you have to enumerate the 5 approaches. Coming to answer. Antenatal steroid, exclusive human milk diet, standardized feeding protocols, avoiding the H2 blockers, antibiotic stewardship, avoiding prolonged antibiotic, risk factor for NEC, and use of probiotics has been found to be useful to reduce incidence of NEC. So coming to last question now. A 20-day-old term AGA neonate with birth weight of 2.7 kg on formula feeds presents with fever, loose stool, and with oliguria, for which baby is treated at peripheral NICU and then referred. So on admission, baby has heart rate of 140, respiratory of 78 per minute. Current weight is 2.1 kg and the lab shows hemoglobin of 20, counts 15,000, platelet 2.5 lakh, sodium 157, potassium 5.1. Urea is 90 and creatinine is 1.9. And ABG is 6.9, pH, PO2 90, PCO2 12, bicarb 2, base excess minus 30, saturation of 98%, and a lactate of 3. What is the likely diagnosis? How will you proceed with management? What is the differential diagnosis to be kept in mind? But this is not a usual typical presentation. Some of you have answered correctly. It is a hypernatremic dehydration with acute kidney injury, but there is a severe metabolic acidosis also there and probable sepsis. So we should send blood culture also to rule out associated sepsis. And we need to have a correction done for the hypernatremic dehydration. So you can calculate free water deficit, generally which is equal to weight loss. In this case, it was 600 grams, so 600 ml. Then in the first emergency phase, you first give a bolus of 20 ml per kg of normal saline over 1 hour. In the rehydration phase, you calculate the required fluid like maintenance 100 ml per kg per day plus free water deficit. So maintenance for say 3 days, which is at for this baby is around 500 odd ml plus deficit that is 600 ml minus the bolus. So around 1 liter or so is the requirement over next for 72 hours. And usually correction is done using 0.45 NS, half-strength DNS. In this case, because there is a severe metabolic acidosis with low bicarb, baby needed soda bicarb injections. Considering this severe metabolic acidosis with such a low bicarbonate, because even on repeat ABG, the bicarbonate is still low after 12 hours, and possibility of renal bicarbonate wasting must be considered, and a distal renal tubular acidosis should be kept in mind. Once you correct, you need to rule it out. The baby continues to lose bicarb, will remain acidotic. After correcting the dehydration, then baby needs further investigations to rule out renal tubular acidosis. So thank you very much.
Thank you, sir. I think it was a wonderful OSCE with all basic concepts and must-know concepts for all students. So thank you very much. And I think with that, we can end today's FEAT session. Dr. Kedar, thank you so much for taking our time.
Thank you, Kavita. Thank you, Dr. Rajesh, for giving me this opportunity. Thank you very much, all those who attended. Thank you.